Good morning, everyone. I am Sonam, Assistant Professor from Nursing Department in RPIIT Technical and Medical Campus. Today, I am presenting the topic episiotomy. What is episiotomy? Episiotomy, firstly, introduction. Episiotomy is a surgical incision of the perineum that is made both to prevent tearing of the perineum and to release pressure on the fetal head with birth. Next is definition. A surgically planned incision on the perineum and the posterior vaginal wall during the second stage of labor is called episiotomy, and the second name of the episiotomy is periotomy. When an incision is given in the perineum for what? To enlarge the vulva orifice, it is known to as episiotomy. Next is objectives. Why we do episiotomy? First, to enlarge the vaginal introitus so as to facilitate easy and safe delivery of fetus, spontaneous or manipulated. Second, to minimize overstretching and rupture of the perineal muscle to reduce the stress and strain on the fetal head. Next is indication. Why we do the episiotomy? What are the indications and in which case we do the episiotomy? First, for anticipating perineal tear. This is widely indicated in semi gravida as an elective procedure. Other indications are like face delivery, if baby is too big, narrow pubic arch, etc. Second is for inelastic perineum. Inelastic perineum in which elderly gravida, old perineal scar of episiotomy. Third is manipulating delivery. This is needed to get more space for operative or manipulative delivery such as forceps, breech or internal version, especially in semigravida. What is semigravida? Semigravida is a woman who become mother first time is known as semigravida. Next is to cut short the second stage in heart disease, severe preeclampsia or in eclampsia. Next is fetal interest, fetal distress to prevent the fetus from fetal distress if the baby is premature to minimize compressions of the short and pliable skull bones, thereby preventing intracranial damage. And common indications such as threatened perineal injury in semigravida, reached perineum if we do forceps delivery, and the positions of the baby is breech, occipito-posterior or face delivery. In all that conditions, we do the episiotomy. Next is timing. In which time we do the episiotomy and what time is the better for episiotomy? First, when bulging thinned perineum during contraction. Just prior to crowning is the ideal time. What is crowning? Crowning is that when fetal head is seen on the vulva is known as the crowning. Types. There are four types of episiotomy. First is medial, next is mediolateral, third is J-shaped episiotomy, and fourth is lateral episiotomy. First is what is median episiotomy? In this, you can also see in the diagram which are in this slide is first. In this type, we give incisions from the center of fourchette and then it is directed posteriorly for approximately 2.5 cm away from the anus. Is known as median episiotomy. And in second, mediolateral episiotomy. In mediolateral episiotomy, you can see in a second diagram which are given in same slide. In this, incision is made from the center from the fourchette, then it is directed posteriorly, laterally, usually on the right side, which is directed diagonally in a straight line, which runs 2.5 centimeter distance from the anus, but not more than 3 centimeters, just remaining in 2.5 centimeters. Next is J-shaped episode. You can see in third diagram in the same slide. In J-shaped episiotomy, the incision starts from the center of the fourchette and then directed posteriorly in the midline for about 1.8 centimeters, then outward toward 7 on the clock to avoid anus. Next is lateral episiotomy. In this incision begin 1 or more centimeters distant from the center of the fourchette. These all are the types of episiotomy. Next is method of episiotomy. How we do the episode. Correct judgment is needed because if it is done too early, it will cause profuse bleeding from the thick vascular tissue or the levator any muscles will be damaged. If it is too done too late, it will defeat the purpose of episiotomy because mother and fetus are subjected to unnecessary stress. Pelvic floor will be overstretched, part of the neck of the bladder become weak, tissue will not heal properly. Correct time for episiotomy. What is the correct time of episiotomy? When the head is well down on the perineum, also known as crowning, and low enough to keep perineum stretched, or when 4 to 5 centimeters of scalp is seen on the bulging thinned perineum. If breech is present, then the posterior buttocks should distend to the perineum. At that time, we give the episode. At the time of episiotomy, patient should lie either on dorsal or in lithotomy position during operation to prevent incision of the labia and slipping of scissor on the slide waist. If patient is at home, keep her in dorsal position because lithotomy position is not possible at home with the hip elevated on a firm pad. Local anesthesia is given to the patient. After giving the anesthesia, clean the vulva with antiseptic lotion. Episiotomy next step 6 point. Before giving incision, mark is made on the skin by needle or reach the point of the scalpel. Next, to protect the fetal scalp from injury by the scissors, 2 fingers are inserted between the perineum and the fetal head. Next, incision should be given during uterine contraction when the perineum is well stretched. Next, incision must be stitched immediately after expulsions of the placenta. Next is care of the episiotomy patient. How you gave the care to episiotomy patient, how you cared a mother. As it is a wound, it needs strict aseptic and antiseptic technique. Wound is gently swabbed with antiseptic lotion and dressed with antibiotic. Then apply sterile pad. A fresh pad is applied after each use of the bedpan. Next is postoperative care. It is two types. First, we do dressing in postoperative care. Next, provide comfort to the mother. Dressing. The wound is to be dressed each time following urination and defecation to keep the area clean and dry. The dressing is done by swabbing with cotton swab soaked in antiseptic solution, followed by applications of antiseptic powder or ointment. To state of healing is assessed by observing for redness, edema, chymosis, discharge, and approximation scale. It is the full form of the RIDA. Comfort. Next is comfort. Comfort to relieve pain in area. Applications of hot or cold stitch bath may be used. Analgesic drugs may be given as and when required. Next is complications. There are two types of complications. First is immediate and second is remote. Next remote complication is dyspareunia and chance of perineal lacration. First, an immediate extension of the incision to involve the rectum. Vulval hematoma also arise and infection is also infections create pain on the perineum, rise in temperature, the wound area look moist, red and swollen, and many times offensive discharge come out through the wounded margin. Next, how we provide care for immediate complications to facilitate drainage of pus if pus is collecting there, then cutting one or two stitches, local dressing with antiseptic powder or ointment, magnesium sulfate compression or applications of heat to the affected area to reduce edema and pain. Next is remote. Remote is two types. First is dyspareunia. What is dyspareunia? Dyspareunia is pain during intercourse is known as dyspareunia. This is due to why we feel pain during intercourse. It is due to a narrow vaginal introitus, which may result from fault technique of repair or due to painful perineal scar. Next is chance of perineal lacerations in subsequent labor if not managed properly. Then we face the chance of perineal lacration.